Hello, fellow colleagues. My name is Dr. Kushan. I am an orthopedic surgeon and specialized in arthroscopy and sports injuries. Today, we are going to discuss about Zealmax Ortho ACL PCL Instrument Set box. I will introduce you and guide you to all the equipments which are necessary for the arthroscopic ACL reconstruction. This is the first tray which contains ACL and PCL zigs, guide pin, 4.5 mm reamer, different diameter reamers for femoral tunnel preparation as well as tibial tunnel preparation. These three are the tunnel dilators of various diameters. This is the second tray which contains aimers for femoral tunnel preparation of both the sizes 7 mm and 5 mm. Then we have the depth gauge to measure the depth of the femoral tunnel as well as tibial tunnel. These are the microfracture owls of different angles. This one is of 30 degree, this one is of 45 degree, and this one with the angle of 90 degrees. This is the ACL screwdriver, and these two are the rasp. One is the convex one and one is the straight one. This is the probe, which is known as the hand of an arthroscopist. These two are the strippers. This is the open stripper and this one is the closed stripper. The third tray contains all the equipments needed to prepare the graft, tensioning, as well as measurements and the preconditioning of the graft. These are to measure the diameter of the graft after preparation. Hello colleagues, today I am going to demonstrate step-by-step technique of ACL reconstruction, which includes femoral tunnel placement, tibial tunnel placement, and fixation of the graft. Whenever we are doing arthroscopy, there are two portals here that we are going to create. First will be the anterolateral portal and the anteromedial portal. Anterolateral portal should be as high as possible, and it is the viewing portal which gives us the view to femoral ACL footprint, while the medial portal, which will be directed directly towards the footprint area using long spinal needle, and precise location of portal is very important for the hassle free placement of tunnels. So anteromedial portal will be our working portal, the lateral portal will be our viewing portal. As soon as we enter the joint, we will do the diagnostic knee arthroscopy to of the all the compartments. After that, we will use probe to check the integrity of the ACL, and if it is torn, we will proceed to ACL reconstruction. This all area will be covered by footprint and the remnants of the ACL. So it is very important to shave off all that area and make it naked so that we can localize certain landmarks that are very important before the placement of the tunnel. After making that area naked, we can use the probe to palpate the ridge and also the bifurcating ridge if it is visible. There are two ways to create a tunnel. If you are a beginner, you should be always using a aimer rather than a microfracture awl directly. First of all, after locating the footprint, we we create a pilot hole in the center of the footprint, which will be equidistant from the anteromedial footprint and the posterolateral footprint. And after hammering it, we will create a pilot hole. Then we will introduce guide pin through it, keeping it parallel to joint. But there is one more way, that there is a AMers are available which are more accurate and also prevents damage to the posterior wall. So we can keep the AMer in such way, but and we have to drill through this to prevent damage to and compromisation of the posterior wall. But one thing is very paramount: whenever you are drilling femoral tunnel, you should be hyperflexing the knee, which allows more space, more vision, and also reduces the trajectory angle and prevents blowout of the posterior wall. So don't forget to keep your knee hyperflexed while drilling your femoral tunnel. Now I am using 7 mm aimer, femoral aimer, to drill with the drill bit to create a pilot drill for the femoral tunnel. This 7 mm aimer gives us 7 mm area behind the drill so that we can save the posterior wall. Drill now. Keep this parallel to the joint. Now we have already drilled with pin or a guide pin in the center of the femoral footprint of the ACL. Why it is very important to drill at the native ACL side? Because if we drill it very inferiorly, it will be biomechanically failure. If we drill it too anteriorly, it will impinge upon extension of the knee. So, and if we drill it very high, it will also lead to early failure of the ACL surgery. Now, we will ream with the 4.5 mm reamer first throughout the length of the guide pin. Then we will go for a particular size of diameter of the femoral reamer to drill. It will depend on the graft diameter. Now we are going to over rim with 8 mm femoral diameter, 8 mm diameter femoral femoral reamer. Now go. After creating a tunnel, we have to measure the length of the femoral tunnel, which is coming around 34 in this patient. And after creating it, the most important thing is to check, use the probe and check the integrity of the posterior wall. It should be intact, and all the debris can be also cleaned while using this probe. You can also switch the camera from anterolateral portal to anteromedial portal, and you can see throughout the length of the tunnel. After now, again from the anteromedial portal, insert the guide pin and load the 8 mm femoral reamer. Guide through the anteromedial portal, which is our working portal, the 8 mm diameter femoral reamer. Now drill only for, here are the markings. We just have to drill for 20. At least 15 mm of graft should be inside the tunnel, and we are drilling here for 20 mm. Drill, drill, to stop. Okay, drill, stop, drill. Okay, here is the 20 mm. Then you have to take it out. Both the things. This is how we create the femoral tunnel, which depends on the ACL footprint, and it should be on anatomically on a precise location, and the diameter of the tunnel depends on the graft diameter. Here we are having graph that we have prepared or managed is of 8 mm diameter, so we have deal with the 8 mm. Now I am going to demonstrate how to drill a tibial tunnel during ACL reconstruction. But before that, we have to make sure certain landmarks, and also we have to identify the big tibial footprint before going to drill a tibial tunnel. So this is a medial tibial spine, and this one is a lateral tibial spine. In front of the lateral tibial spine, this orange, which I mark with the orange thing, is a anterior root of the lateral meniscus, and just in front of that, this hole is a tibial footprint of ACL. We have to drill exactly into center of this footprint. Usually the tibial zig is used, and the angle can be kept between 45 to 55 depending on the anatomy of the patient, and this is the aimer which help us to drill where we want to drill in the tibial footprint. Okay, this is the ACL elbow aimer. This is the elbow that we have to keep just anterior to the anterior root of the lateral meniscus, and we have to keep it like this over the anterior root of the lateral meniscus. Then we have to push it until it reaches the bone, and after that we have to tighten it so that it doesn't fall. This is how we create it. It should be like this only. Tunnel should not be too anterior. It so this way we can create the native ACL anatomy and restore the native ACL biomechanics and stability. Now drill. Using this ACL elbow aimer, we created a trajectory for reaming the tibial tunnel, and it is in the center of the tibial footprint, just anterior to the anterior root of the lateral meniscus. Now we have to again confirm, and for to confirm that we can also change the portal if it is not visible clearly. Now we will over rim this guide pin with the 8 mm diameter reamer, and then the tibial tunnel will be ready. Then we can pass the graft and fix the graft at the femoral side, followed by the tibial fixation, which can be with the screw or with the tibial screw. Now we are over reaming this guide pin using 8 mm diameter tibial reamer. Okay, go slowly. Okay, second, 1 second. Now ream. Whenever the patient is young and the bone quality is very strong, first you should ream with 4.5 mm reamer, then directly rim with 8 mm diameter reamer, as it is the bone model and it is not as strong as human bone. So whenever the patient is young and we are doing this surgery, you should first create over rim with 4.5 mm reamer, followed by the 8 mm or the diameter of the graft. It will prevent the heat induced necrosis of the bone. Now after creating tunnel, you should also measure the depth of the tibial tunnel by keeping you're using your anterolateral portal as a viewing portal. It is for the very rough idea. If we are using a screw, if we are doing suspensory fixation at the tibial end, we don't need to measure the length of the tibial tunnel. After placement of femoral tunnel and the tibial tunnel, we have to pass a loop from the hollow portion of the proximal end of the bitpin and from the anteromedial portal we have to pass it through femoral tunnel. Now hold the loop part and take out the free ends of the suture from the femoral part. Then using hemostat tie the free ends. Now with controlled pulling of the threads, keep the loose ends into the joint, and then under the camera control, pull out the loop. Pull out the loop outside the tibial tunnel. Now we are ready to move our graft into our both the tunnels. This is the graft board on which we have artificially created a graft of 8 mm diameter using two strands, and we are using the adjustable loop here, which gives us more leverage in our measurement problems, or maybe some miscalculations can be overcome by the use of this adjustable loop, and we can also tension the graft after flipping the endo button. Our femoral length of the femoral tunnel is around 34 or 35 mm. So first from the button we will mark all the fibers circumferentially at 34. Then also keep a 5 mm of marker ahead so that we can know when to flip the button. We have drilled the femoral tunnel as per the diameter of the graft for 20 mm. So from the loop end we have to mark it over 20. Mark it circumferentially, and there are high chances that the two strands will separated while passaging the graft into the tunnel. So it is always wise to use a fiber wire at the same place. Take a note over the area where we have marked, and we can also tie it like this, and we can also do this to make it more thicker. Loop, one loop, this is one. We can create up to 5 or 6 loops. The second loop, I usually create 4 loops. After that, cut it. Don't make it too thick, otherwise it won't pass through the narrow 4.5 mm femoral tunnel beyond the 20 mm from the femoral margin. Suture. First of all, settle it while from this loop under viewing form viewing portal. Now we have our all fibers outside the femoral tunnel. Now this fiber we have to confirm by pulling it from the other end. The white fibers will be used to fix the graft once the button is flipped over the lateral femoral cortex. So now I am pulling one tiger fiber wire and under viewing. Now our button has passed the tibial tunnel. Whenever there is a slake, you pull the another tiger fiber wire to to clear the slake. Then again take another wire, again clear the slake. Now our button has entered into the femoral tunnel. Okay, I'm again clearing slake. As our button has passed the our marking of 34, we should uh, we should flip the button, and now our femoral fixation is done. Now clear the slake of the wire by pulling another one. Now we have to move this graft into the joint. For that, we will be having two plain white threads. Now our graft is moving towards, okay, it will create resistance as there will be bony debris into the canal. Now pull both the white threads, and as soon as that it reaches our marking, we can tighten it. Now this is the tibial free end of the graft, and the graft is now fixed. Now we can fix this tibial aperture with the interference screw. As we are having very long or a prominent tendon, it will be wise to fix it with the interference screw, which gives us a robust fixation, and we can start the rehabilitation protocol as early and go somewhat faster if patient requires that. Even we can do the suspensor fixation here. Okay, after fixing the graft at the femoral lateral cortex, first thing we have to do is to, with our maximum strength, we have to pull it down. It should not be coming out. Then after confirming the fixation, we have to go for a 15 or 20 cycles of cycling to tension and the conditioning of the graft while maintaining pulling pressure at the tibial end. After completing that, we have to extend the knee, and we have to pass a guide wire for the screw insertion, interference screw insertion. And if we have drilled with 8 mm diameter, then we have to use a 8 mm screw less than the tibial tunnel. Here our tibial tunnel is 25. So we have to use a screw which is less than 25 mm in length, and the diameter should be 8 mm. And while fixing the screw, we have to give posterior thrust to the tibia, and while maintaining it, we have to fix the tibial aperture using an interference screw of appropriate length as well as diameter. After the cycling, we have to extend the knee and maintain the 10 degree or 20 degree of flexion at the knee joint, and use the appropriate size of interference screw after passing the guide pin in this joint, and clear the soft tissue around this hole. Then only pass the guide pin, and then only pass the screw of appropriate diameter and length. Our tibial tunnel length was 25 to 28 mm. So we have to use a screw which is less than the 25 mm in diameter, in length, and diameter should be 8 mm. After fixing it from the tibial end, always check with anterior drawer test and also for the latchman test to check the stability. Don't use excessive force as it can lengthen the graft, also create the unnecessary tension in the graft. So use a moderate amount of force to check the stability post ACL reconstruction.